males below the age of 40 ranges from 100 to 130 milliliters, and in young women from 90 to 120. Then you have the stages grade 1 and 2 and stage 3A and 3B, and until you reach end stage renal disease, and in this category there is the highest risk of cardiovascular and total mortality, and also particularly in patients on dialysis. Next. So the risk of cardiovascular MACE and death increases progressively with reduction in the GFR. There is a particular jump at GFR less than 45. That is, as you move from stage 3A to 3B, there is a twofold increase in risk. And then as you reach stage 5 and in patients on dialysis, the risk increases tremendously, 5 or 10 times or more. Next. And this is a population study in patients over the age of 66 years, and the adjusted mortality rate in cohort with chronic kidney disease versus no chronic kidney disease shows the high risk in these patients. The adjusted mortality rate in the absence of chronic kidney disease is 54 per 1,000 patient years. And in the presence of chronic kidney disease, it is 64 per 1,000 patients in the earlier stages. And as you reach stage 5, it is 266, more than a 5-fold increase in risk. You can see in the A section of the pie charts that congestive heart failure makes the bulk of this risk, and that the patients who are care, the cardiovascular events and are 40%, whereas in the absence of kidney disease, 2/3 of the population are spared this effect. And in B, there is a breakdown of the causes of mortality in patients on dialysis. And as you can see, it ranges from acute myocardial infarction, heart failure. Again, the greatest bulk here is arrhythmia, cardiac arrest, and sudden cardiac death, which forms 26% of the total, and 60% of the cardiovascular mortality. The presentation in these patients with chronic kidney disease, the presentation of coronary artery disease is atypical. They do not present with stable pectoris. They present more commonly with an acute myocardial infarction. Non-STEMI, more common than STEMI. Chest pain is less common than in the absence of chronic kidney disease. Silent ischemia is prevalent. Next slide, please. And I'm putting this slide back. I would like to ask Dr. Omar, how should we use the albumin-creatinine ratio in this algorithm of risk in these patients, Dr. Omar. لأنه مثلا in the later stages of kidney disease, the risk is already very high. So when should we perform the albumin-creatinine ratio, and how should we use it, and what is its implications for management?
I think the albumin-creatinine ratio is important in the early stages of renal failure up to 3A or starting to 3B. 3B and stage 4 and stage 5, the albumin-creatinine ratio really does not differ in the prognosis for the kidney. This kidney is going to be lost. With stage 4 with 3B ده مش يعني it's not a really high level of creatinine, because you know stage if you say GFR of 30 or 15 to 30 in stage 4, that's creatinine 3. يعني most of our patients are in stage 5, as a matter of fact. So in this population, there is no point to do the albumin-creatinine ratio. It doesn't help in anything as regard at least the prognosis for the cardiovascular system and the renal prognosis. And as you know, when the GFR drop significantly, the albumin excretion also drops significantly. So it's useless to do, really useless to do albumin-creatinine ratio in the late phases of renal failure. But in the early phases, it is important, because in stage 1 or in stage 2 or in stage 3A, it is important because you can have a higher cardiovascular risk if you have a higher mortality, and a higher rate of kidney deterioration if you have a higher albumin-creatinine ratio. But yani, we don't use it in the late phases, we use it in the early phases.
All right. I'll follow by a second question, but I would like to remind the residents with young staff at our department, we should always use an estimated GFR formula to judge management in these patients, to renally dose the drugs and to evaluate the risk. We should not rely on serum creatinine, and we should always resort to the albumin creatinine ratio evaluation. برضو, I think it's forgotten by many cardiologists when it is needed. Like I'm going.
I would like, yeah, okay.
Yes,
I would like to tell you that there was in the very old nephrology history, we used to divide 60 by the serum creatinine, and this gives the creatinine clearance. Of course, this applies if the serum creatinine is already above 2. It does not apply to the early phases. So the EGFR might be very important in the early phases, but in the late phases, you can simply divide 60 by the serum creatinine, you get the EGFR in a very simple way. But this, of course, may have some fallacies if the patient is too cachectic, if the patient is not eating protein well, and that's why the EGFR would be more of accuracy in a way for this simple equation. But it is a very useful equation. You divide 60 by the serum creatinine, you get the creatinine clearance or the EGFR in most patients with creatinine above 3. Yeah.
Yes, thank you, Omar. Now I'm going to ask you about this segment of the population who have early stage renal disease, because yes, we have all the studies concentrating on end stage renal disease, and we know why, of course. But it is said that in the adult population, 6 to 10, maybe 10% of the adult population may have an early stage renal disease because of the increasing incidence of, aging, diabetes, and hypertension. And I don't think we pay enough attention to these patients, and I think that they are at risk. For instance, these patients with early stage renal disease are more likely to die before actually they need or they undergo a progression of kidney disease and they need dialysis. So what do you think? And is this an area open for research?
Yes, of course, this is an area of research, but there are several points in this regard as the early phases of the early stages of chronic kidney disease. There is a debate whether this is the normal decline with age, which is not a universal decline, by the way. Not all people get declines in kidney function, but most people in their late phases of life get some decline of kidney function. Is this renal failure or not? I think there is a great debate about that, and that's why the instance of renal disease is variable, is subjected to variable views. Is this true renal disease, or this is just aging? Because you can have an instance of 15%, for example, in some community, 10% in some community. But actually, I think the incidence is less than that, a little bit less than that, because we are included patients who are physiologically, that's the physiology, that's the normal physiology, GFR drop by age. It was said in the past, it dropped around 1 milliliter per minute after the age of 40. But of course, this is not a universal statement. Some people, minority of people, can conserve their kidney function till the end.
Thank you, Amar. Let's move to the next slide, please. Yes. So you all know about these two recent studies, ischemia in stable coronary artery disease patients and ischemia, chronic kidney disease. And the two studies are contemporary. The two studies were done in the same centers. They had very similar protocols. They have stringent criteria for exercise imaging tests. They had highly optimal medical treatment with successful results. In ischemia, chronic kidney disease, the GFR was less than 30 in all patients. 50% of patients were on dialysis. So this is the segment of highest risk, as we just explained. They all had stable coronary artery disease in that sense. They all had stress-induced moderate to severe ischemia, moderate in 2/3, severe in 1/3. And as we know from the clinical presentation of these patients, there was no angina, no chest pain in 50%, and rare angina like monthly angina in 40%. In the, of course, you know that this study, they tried to examine whether an initial invasive strategy versus a conservative strategy will have any effect on the cardiovascular outcome in these patients, and there was no effect. In the invasive group, 26% of patients had non-obstructive coronary disease. And this is something that we will go back to. This is something that needs to be looked at. Multi-vessel disease in 50%, and as usual for the practice nowadays, PCI versus CABG, 85% PCI. Next, please.
دكتور ياسر.
ايوه يا دكتور محمد، هو الدكتور شريف سكت خالص.
لا انا ما سكتش، قلت لك نكت. انا اسف انت ما سمعتنيش. Thank you, yes. So if we look at the conservative strategy group, and this is the 3-year cumulative endpoints. Actually, this is like looking at the natural history of chronic kidney disease in patients with a GFR less than 30, because only 20% had revascularization. And you can see the large mortality. 40% of patients were either dead or had an MI by 3 years. Myocardial infarction, 17%. And in the group of patients who were not on dialysis, they had a 50-50 chance to die rather than reach the initiation of dialysis. Even in the invasive group, coronary angiography was scheduled 30 days after randomization. And 6 patients, 1.5% of patients in the invasive group died before they can have a coronary angiogram. Horrible. Now, if you compare this with the results of ischemia in the general population, and these were all of them, almost 90% of them, they had a GFR over 60, and only a small segment between 30 and 60. Then they show us the figures that we know in the conservative group, in the natural history of stable angina pectoris, cardiovascular death, 4% at 3 years, that is slightly more than 1% per year. So now these two groups were very similar. They had similar increased prevalence of risk factors. They had similar age. They had similar positive myocardial ischemia and stress tests. And yet there is this huge difference in mortality and in events. So this cannot be stable coronary artery disease in patients with chronic kidney disease. Stable coronary artery disease behaves like what we see in the ischemia studies. It does not behave like what we see here. So there must be another factor. Stable coronary artery disease here, in my opinion, is a bystander. It's a cofactor for event production. But this is not stable coronary artery disease alone causing this large mortality. Next, please. So there is this concept that as the GFR declines, you have 2 risk pathways. One in yellow is the atherosclerotic cardiovascular events, coronary, cerebrovascular, peripheral vascular, systemic vascular. But the other course in violet is non-atherosclerotic cardiovascular disease. This is the result of the toxic milieu of renal failure. This is the result of bone mineral disease, increased levels of phosphate, phosphate calcium, abnormal phosphate calcium metabolism, arterial calcification coupled with inflammation, oxidative stress. There is increased peripheral vascular resistance. There is increased pulse wave velocity. There is reduced elasticity of the aorta. These factors increase left ventricular afterload in systole and reduced coronary perfusion pressure in diastole. And these factors And this large component of mortality that increases as the GFR is reduced is not related to coronary atherosclerosis. Dr. Omar?
I am.
Would you like to comment on this?
Well, you know that the renal failure, chronic renal failure patient has traditional risk factors which may be present or may not be present in a severe way, but he has also non-traditional risk factors. And the non-traditional risk factors play an important role as the stage of renal failure decline or the become stage 4 or 5. And non-traditional risk factors include the calcium and phosphate, the hyperparathyroidism, the anemia, the aluminium problem in some dialysis centers. There is a lot of other non-traditional risk factors, the homocysteine, for example, non-traditional risk factors that play a major role in the late phases of renal failure. Besides, of course, they are subjected to the usual risk factors like smoking, hypertension, and so on, as you said. So the non-traditional risk factors play a major role in stage 4 and 5. And these starts actually early, and these should be attacked in stage 2 or stage 3A so as to protect the cardiovascular system.
Okay. And Dr. Omar, also there is evidence of for a uremic cardiomyopathy, a chronic kidney.
Yes, of course. Yes, the uremic milieu itself, yes. Yes.
And in earlier studies where they used the MRI before the realization of the threat of nephrogenic systemic sclerosis, there were some studies that showed patterns of myocardial fibrosis by late gadolinium enhancement, that some patterns are consistent with coronary artery disease. There is subendocardial fibrosis, but there were other patterns of mid-wall fibrosis, sometimes focal, sometimes diffuse, probably as a result of inflammation. And
yes,
as you were saying, this segment of risk, this risk pathway needs a different approach, needs a different treatment. This will not be corrected, as I understand, with medical treatment for coronary atherosclerosis or revascularization for coronary atherosclerosis. And there have been actually some attempts, like using the aldosterone antagonist to reduce myocardial fibrosis, or coupling an aldosterone antagonist with one of the newer agents that combat or reduce hyperkalemia. And there is at least one study that showed that this can reduce the mortality in patients with late stages chronic kidney disease. Dr. Omar.
Yes, the entity of uremic cardiomyopathy, there has been a great debate about its existence, but in the recent literature, they are approving. I mean, there is an entity called uremic cardiomyopathy, definitely. It's one of the non-traditional risk factors in the uremic patients. But one point I want to clarify is the sudden cardiac death. Sudden cardiac death is very important in dialysis patients, particularly patients on regular dialysis. And it represents a good amount of the mortality in these patients. And a lot of studies have been made that showed that sudden cardiac death in dialysis patients is almost always related to hyperkalemia, and that most of these deaths occur in the period of long non-dialysis. For example, when dialyzed 3 times per week, there is an interval of 3 days without dialysis. مثلا سبت 2 4 الخميس والجمعة وبعدين يغسل السبت. So these 2 days are very critical. أو حد وثلاث وخميس مثلا، يبقى من الخميس للحد فترة طويلة. يعني دايما the dialysis patient, we dialyze patients 3 times per week, and this is the conventional international way of doing regular dialysis. So in this 3 weeks, 3 days per week dialysis, always in the long period, there is a risk of cardiac death, and a lot of studies have been done that shows that if you do dialysis every other day, not 3 times per week, every other day dialysis, the sudden cardiac death decreased significantly. And it is very wise to do dialysis every other day, but practically it's not easy to perform it for many logistic lesions, because you know, every other day, so you will work on Friday, the nurses don't want to work, there is a problem I mean, it's not practical to do it, but this is the most scientific way to doing dialysis, is every other day and not 3 times per week, to avoid the risk of sudden cardiac death.
Okay. ولكن برضو يا دكتور عمر, the most successful treatment that we have for this segment of non-atherosclerotic risk in these patients is kidney transplantation.
Of course, of course.
Next slide, please. So kidney transplantation transforms the lives of these patients on dialysis, and you can see the difference in survival curves over 5 years here from a United States registry. Next, please. And so if the mortality in patients on dialysis is 9% and probably higher than that, I've heard figures in Egypt close to 20% annual mortality. In renal transplantation, it is less than renal transplant patients. It is less than 1%. Kidney transplantation actually may add 10 years to patients' lives by staying away from dialysis and going to transplantation. And this is probably because it's associated with reversal of many of the factors that are associated with this non-atherosclerotic risk in these patients. Unfortunately, and as you see in the pie chart, cardiovascular disease remains again the main cause of death even after renal transplantation, but this is for other reasons. Dr. Omar?
Yes, I want to comment on the curve of the survival for renal transplant patients and the dialysis patient, because one might argue that the transplant patients are selected patients, that are the best dialysis patients that are transplanted. But this is not true, because very proper statistics have been done to clarify this point, and they took the patients who were put on the waiting list. You are on the waiting list if you are fit for transplantation. Some of these patients get transplanted, some of these patients are unlucky to find a suitable kidney, and they are delayed in their transplantation. And the comparison between the two groups, these are two dialysis groups that both are fit for transplantation. The transplanted patient definitely has a higher survival, as you mentioned in your slide. So transplantation surely has a higher survival than the remaining on the waiting list. فما بالك الدياليسيس بيشنت اللي هو حتى ما اتحطش على الويتنج ليست، اللي هو عنده كوموربيديتيز اخرى، طبعا ده ضايع خالص.
And the message here, Dr. Omar, is that in this study of ischemia, chronic kidney disease, where they addressed what they thought is a stable angina pectoris, the proper intervention was renal transplantation.
Yes, of course.
Artery revascularization, or maybe kidney transplantation coupled with coronary artery revascularization if you want to improve the mortality in these patients, but probably I don't know if this is logistically possible and how many patients it is logistically possible, taking the large bulk of patients with end-stage renal disease. Next slide, yes.
This is true, but Sherif, I want to comment on this, the last slide on the 37% mortality of the transplant patients are cardiovascular. And this is true, definitely, because in renal transplantation, you are using steroids and cyclosporin. And both are atherogenic and have a bad vascular effect. And this is one of the main reasons that the cholesterol and the lipids should be monitored regularly in these patients, because the use of steroids over long term implies a definite cardiovascular mortality.
All right, this is the relative risk of death in patients on dialysis. This is a large number of 46,000 patients, and they are the stable dashed line, the reference line, and the continuous line is the risk of death after kidney transplantation. And I'm bringing this slide, of course, the risk of death is lower after kidney transplantation, but look at the first couple of months or the first few weeks after renal transplantation, and here there is a higher risk of death in transplanted patients, and this is the mortality or the risk of surgery. And this is one thing we should address when we assess the cardiovascular risk in these patients. This is, and these are, I think, all data, and I think that this relative increase in risk of death after the operation has been reduced nowadays. Next slide, please. So kidney transplantation at the end is classified as intermediate risk surgery. So the mortality is 1 to 5%, as you know. But you cannot treat it as any non-cardiac surgery in a cardiac patient for these considerations. First, there is a very high prevalence of cardiovascular risk factors. Hypertension in ischemia, chronic kidney disease was present in 90% of patients. Next, second, it's a precious surgery. It involves a donor and a donor's risk. And the risk of allograft failure it would be a terrible experience for the recipient and for the donor, both. And of course, as we just mentioned, it is the best known therapeutic intervention to improve quality of life and increase longevity in end-stage renal disease. It's a very precious surgery. Next, please. So when you are faced with this decision-making, when you are asked by the nephrologist, is this patient fit for renal transplantation or not, you should be very careful. Of course, you do not want to subject very high-risk patients to surgery. You do not want to lose the patient. On the other hand, you want to strive to send all these patients to kidney transplantation, because this is the real life-saving intervention for these patients. Next, please.
Sherif, can I intervene in the last slide? Just a small word. The third option, of course, you need to assess is the relatively long-term survival of the patient. Is this patient with this having this heart is going to survive for more than 5 years or not? That, of course, الأعمار بيد الله, ولكن في medical opinion. So it is very important that the cardiovascular system of this patient is going to make him live for more than 5 years, because this is the one of the basics rules of transplantation, is that you don't transplant any patient whom you expect him to die in 1 year or 2 years. This would be a wrong decision, because you are taking a living kidney which is going to be lost within 1 year. So the long-term cardiovascular system of this person will allow him, provided he has good medical management, of course, will allow him to live more than 5 years. So this is one of the questions we ask the cardiologist to answer us, because he may be fit to do an operation now, but this person is not going to live for a long time.
Thank you, Omar. So what do we do for risk assessment? We go along the usual algorithm in patients going for cardiac patients going for non-cardiac surgery. First, we identify patients with active cardiac conditions, acute coronary syndrome, decompensated heart failure, severe valvular heart disease, arrhythmia, and so forth. أنا أول ما كتبت الجملة دي أنا كتبت we exclude patients with active cardiac conditions, and then I changed it to we identify, because I believe we should not exclude any patient. We should try to correct the active cardiac condition and then try to have transplantation. Next, of course, is the functional capacity, and you all know, is the patient able to climb 2 flights of stairs? Is the patient able to walk 2 or 3 blocks? Is he able to perform his routine daily activities? Patients with a poor functional capacity, less than 4 meds, have a high operative mortality. Patients with an excellent functional capacity, those who swim or play tennis, they will have a very low event rate. And then, as the guidelines from the American Association, the guidelines from the kidney associations mention, you have to look into the clinical risk factors, age, diabetes, hypertension, so forth. Importantly, history of previous cardiovascular disease, a patient who had TIAs or had a stroke, and the number of years on dialysis. Of course, every one of these points has its own caveats. For instance, clinical risk factors more than 2 or more than 3, they will be present in all patients with end-stage renal disease. So their value is not as important. Then on the echocardiogram, I picked up 2 points. There are other points, of course, echocardiography, LVH, left ventricular mass, and so forth. But the ejection fraction is important. And there is a large increase in short and long-term cardiovascular mortality if you send a patient for the operation with a reduced ejection fraction, probably less than 30%. So what do you do if you can, with medical treatment or with resynchronization therapy, improve the ejection fraction and then send him to surgery? Also, the level of the pulmonary artery systolic pressure, mostly as venous increase in pulmonary artery pressure because of left ventricular disease, should not exceed 45 millimeters of mercury, and if it's more than 60, then this is really risky. Next. Then we come to the question of non-invasive tests. And the important question here is, what are you using these non-invasive tests for? If you are using them to detect coronary artery disease, they have a poor sensitivity and specificity. It is better if you use them for prediction of MACE and cardiac death. Then they perform better. Negative predictive value in most of these tests is better than the positive predictive value, so that if the test is negative, you can have a reassurance that of a good cardiovascular outcome. There is no evidence, of course, that using these tests improves by any means the cardiovascular outcomes, but this is important when the patient is going to have a kidney transplantation surgery. Then you have greater benefit from these tests. Troponin T is a marker of myocardial necrosis. It's associated with increased mortality. Any elevation in high-sensitive troponin or troponin T is associated with an increased risk of surgery and an increased mortality. The problem is that it is non-specific because it's already elevated in like 30% of patients with chronic kidney disease because of hypertrophy, silent ischemia, hypertension, other factors. And it has not been really validated in outcome studies. Coronary artery calcium score is a very nice test because it involves very little risk to the patient. As the GFR declines, coronary artery calcium score increases. Calcification is present in like 80% of patients with end-stage renal disease. You know that there is subintimal calcification, and this is the result of the atherosclerotic pathology, but there is medial calcification, and this is a result of chronic kidney disease, also occurs in diabetic patients. So why do we use it? Because it's predictive. It is predictive of mortality, and it is predictive of MACE in these patients. The stress imaging tests, the vitamin stress imaging and myocardial perfusion imaging, of course, are also valuable. They have been used for many years. If you have evidence of ischemia, there is a 6-fold increase in the risk of myocardial infarction and a 4-fold increase in the risk of death. On the other hand, if you have a normal test for ischemia, you have less than 1% perioperative event rate. So the coronary artery calcium score measures coronary atherosclerotic burden, while these other two tests, they measure ischemia. An important point about coronary artery calcium score is that it also may be related to this segment of non-atherosclerotic risk in patients with chronic kidney disease. It may be related to increased vascular resistance, left ventricular hypertrophy, increased left ventricular mass, and sudden death in these patients. Finally, coronary CT angiography. This is also useful. High negative predictive value if it is normal. If there are no significant coronary artery stenosis, the patient can go and have surgery. It carries the risk of contrast nephropathy. The risk is more in diabetic patients, and if you use more than 0.8 milliliter per kilogram of contrast, it can be used, of course, in patients who are already on dialysis. Dr. Omar, what do you think of using contrast in patients who are already on dialysis, and is there any value of performing like dialysis after the procedure?
Yes, because of course the dye is nephrotoxic, and these patients, although are on dialysis, they have what we known as the residual kidney function. the residual kidney function makes them say they have a GFR of 8 milliliter per minute or 7 milliliter per minute. And this residual kidney function remains for 1 or even up to 2 years after start of dialysis. So in this population, particularly those who started dialysis a little bit early and have a GFR of 7 or 8, they have some residual kidney functions that can help them to make urine, to avoid the overhydration and to drink more water than their counterparts. And it also improves the patient a little bit. This minor kidney function is important for the patient's well-being. If you use dye unnecessarily, you are going to destroy this residual kidney function. But of course, if the patient is on long-term dialysis, say 4 years, 5 years on dialysis, I don't think that the dye has any effect on the kidney. There is no kidney, actually.
And should these patients who are still early on dialysis, should they have dialysis immediately after the procedure?
No, I don't think, Professor Sherif. No, I don't think so. I don't think so. There is a lot of studies that have been done on this point, and they all proved that dialysis after dye injection is useless. And this is very simple to explain, because the dye causes an immediate injury. When you, with the termination of your injection, the kidney is already damaged. You have done the damage. It's an immediate effect. So taking the patient to dialysis after that, 2 hours or 3 hours of dialysis, and after 3 hours of the dye injection, I mean, and then you dialyze, in order to remove the dye already has caused its damage. The damage has been done. As there is no point at all to do dialysis after dye injection. With a very, very rare exception is that in some patients who have some neuroelectrical problems in their brain might get some convulsions after dye injection, because the dye is concentrated and this causes some electrolyte shift that can cause some convulsion. In this particular situation, dialysis might be effective in removing the dye, but you don't remove the dye because the kidney has already sustained the damage. ده حاجة سريعة خالص، يعني حاجة زي واحد ادى واحد بوكس، ما فيش فايدة بقى ان امسك اللي اداله بوكس ده واعمل له خلاص هو البوكس اتضرب خلاص.
It's a direct cellular toxic effect. Thank you, Omar.
Yes, direct and rapid.
Yes. So the best is to use a combination of tests. Next slide, please. Yes. You look at the patient functional capacity, you look at the number of clinical risk factors, you look at all the echocardiographic parameters, you look at the calcium score, and maybe you choose one of the ischemia revealing ischemia tests. You have seen how the myocardial perfusion imaging, how it performed in patients with in the study of ischemia and chronic kidney disease. 26% of patients turned to have no obstructive coronary artery disease, although they had a positive moderate or severe test. So this means a positive predictive value of the test of only 74%, and this is the usual for these tests. But this is from one study where they tried to use this combination of risk factors, and on the left is MACE, and on the right is the mortality. And if you look at the last figure in the mortality, using a combination of clinical risk factors and coronary artery calcium score, more than 400 or less than 400, you can identify in the bottom of the figure, you can identify a group with very low risk this was actually not for preoperative assessment of kidney transplantation, but you can identify a group at very low risk of 1 to 2% mortality if you have these two together. Next. And this is from another study, and it shows that, again, if you use a combination of tests, baseline is clinical factors only, baseline plus two-dimensional echo. Then you add segmental wall motion abnormality, ejection fraction, left ventricular mass, baseline plus 2D echo plus SPECT. Then you get an incremental increase in your ability to define high-risk cases, and you get a higher receiver operator characteristic curve with better sensitivity and specificity as you use a combination of tests. Next, please. So we come to the immediate operative and perioperative period, where there are large shifts in fluid balance, electrolytes, where you need to regulate the blood pressure. The first 2 or 3 days after operation are the days when you can get heart failure or myocardial infarction or cardiac arrest. دكتور عمر أنا أسيب لحضرتك discussion of this slide.
As you showed before, that the two major really risk factor is the ejection fraction below 35, and I think we should not transplant patient with a persistently low ejection fraction. This is very, very serious, and this is for myself is a contraindication. The second is the pulmonary hypertension, as you mentioned. The high pulmonary hypertension above 60 or around 60 might be a very hazardous factor in the early massive fluid infusion given in the early 48 hours post-operatively, and this is very serious. These patients should be monitored much more carefully than the ordinary patient. But I see here in this slide of complication, I don't think myocardial infarction occurs in 25% of patients. No, we have not seen that. ولا cardiac arrest. يعني really important events that occur in the early post-operative are quite rare if you properly choose the recipient, and if you don't take a major risk to do the transplant in a patient you know he's going to complicate. And this has been learned through several cases and problems which I encountered. I think to be on the safe side is better.
Myocardial infarction, Dr. Omar, represents about 1/3 of the cardiac complications, but the figures on the right side, Dula, they show the hospital mortality. And again, probably the hospital mortality of myocardial infarction in the perioperative period currently is less than that, but of course it's higher than myocardial infarction in the non-perioperative period.
Yes, yes.
Next slide, please. So, why does myocardial infarction occur in the immediate post-operative period? This relates, of course, to the stress response to surgery. You all know the combination of pain, tissue cutting, inflammation, inflammatory mediators, hypercoagulable state, and so forth, and the changes in sympathetic nervous system, increased heart rate, changes in blood pressure, all are triggers of myocardial infarction. There are very interesting studies of the coronary pathology in fatal myocardial infarction after non-cardiac surgery. This is not specific for kidney transplantation. This is after non-cardiac surgery. And these studies, they showed that 2/3 of the patients have either left main or free vessel disease. So this is a warning that you should probably revascularize these patients before you send them to kidney transplantation. In the pathology studies, they also showed that plaque fissuring is uncommon, and only 1/3 had intracoronary thrombus, probably alluding to that these are type 2 myocardial infarctions. These are patients who had increased myocardial oxygen demand because of the stress response to surgery in the presence of a severe coronary artery stenosis, and so they sustained myocardial infarction, commonly a non-STEMI. On the other hand, there is a study of coronary angiography in patients with non-fatal myocardial infarction, and they showed actually that these patients, they have an infarction because of plaque rupture, like the non-operative infarctions. But the majority of these infarctions were in arteries without high-grade stenosis. So this tells you that it may not be of value that you revascularize these patients by stenting high-grade coronary artery stenosis before surgery. Next, please. So what preoperative interventions do we have? We have to optimize medical treatment, beta blockers, statins, and aspirin. And I will not discuss the medical treatment because it is very nicely discussed in details in the guidelines for management of patients with cardiac patients going to non-cardiac surgery. And coronary revascularization. So should we do coronary revascularization? There is no evidence whatsoever. All the studies that were performed in patients going to non-cardiac surgery, coronary revascularization, and the meta-analysis of all these studies showed no effect on operative mortality or myocardial infarction. The CARP study, the DECREASE family of studies, there is no evidence at all. And of course, there are no studies in patients with in renal transplantation. Next.
دكتور ياسر بيسأل البيري اوبراتيف مورتاليتي في مصر. تحب اجاوب ولا اكمل انت الاول؟
انت جاوب طبعا.
لا صحيح. هو طبعا البيري اوبراتيف mortality is not a common thing. It's a very rare thing, particularly when you properly choose your recipient, as I mentioned. I think the rate of 2 or 3%, not more than that, would be a close figure to the reality. I am afraid here that the most important cause encountered in Egypt for the perioperative mortality is infection, severe infections that lead to death of the patient, septicemia and death. Of course, coronary problems in these patients, you can encounter it. I hope I don't encounter these cases, but as you mentioned, Professor Sherif, that the patient with left main artery problem and left descending artery, anterior descending artery problem and the left main problem, and the patients with 3-vessel disease are definitely a very high risk for perioperative cardiovascular mortality. But the point is, how can you detect these patients if they are not clinically evident? The patient does not have any angina, ejection fraction 54 or 55, he's doing well, and he's playing tennis. How can you be sure that this patient does not have a 3-vessel coronary artery? You cannot be sure except by doing angio, and you cannot do angio for all these patients, of course. So this is one of the questions the nephrologist, when he sends the patient to you, he wants you to advise, is this patient is better to do angio or not?
Well, Dr. Omar, if the patient is asymptomatic, or even if he has stable coronary artery disease, and
Yes.
he plays tennis, then it doesn't matter if you have 3 vessel disease and you can send him to surgery.
Oh, that's very good. That's very good. That's a very important point. So you are not committed to detect all the patients on by doing angio.
Yes. So what is the value of revascularization? These points are from the text of the discussion of ischemia, chronic kidney disease. They refer to the high upfront risk of procedure complications, which reduces the yield or the benefit of revascularization. طبعا in patients with chronic kidney disease, this is a risk of contrast. And in this study, there is a very nice protocol for the use of contrast in these patients. And you should all look at this protocol. It's in the supplementary, it's in the supplement of the study, not in the text of the study. And you should look at this protocol and you should all follow it. Of course, the other risk, and this also occurred in the larger study of ischemia, is the procedural myocardial infarction. There was a higher risk of procedural myocardial infarction in the invasive group and a lower risk of a spontaneous myocardial infarction in the invasive, in this invasive group. Reduced long-term durability of revascularization because these patients with chronic kidney disease, they do not have stable coronary artery disease. They actually have a very active coronary artery disease. And the long-term durability of revascularization, I'm going to show you the results of stenting in the Korean study, in the next and last study, is due to new lesions in non-stented segments. And they occur very rapidly, and they cause this high risk of infarction and mortality in the first 2 or 3 years, even after revascularization. And of course, there is the point of the risk of death from non-atherosclerotic causes, as we discussed, so that if you perform coronary revascularization, you may not be addressing the mechanism of death in these patients. Next, please, Yasser. And this is the procedural myocardial infarction risk, higher in the invasive than in the conservative group. Next, Yasser. And this is the Korean registry. ياسر في سلايد تانية بعد دي ولا خلاص؟
اعتقد دي اخر واحده يا دكتور شريف.
طيب I had a slide that shows the appropriate use criteria for coronary revascularization in renal transplantation. You can find it in the 2017 guidelines of the American College and the American Association, the appropriate use criteria. Appropriate use criteria in patients with stable coronary artery disease in this situation are very similar to the appropriate use criteria in patients with stable coronary artery disease anywhere. You apply the same parameters. Is it 2 vessels, proximal LAD, no proximal LAD, diabetes, no diabetes, syntax score above 22, below 22, left main, site of left main, 3 vessel disease. You apply the same criteria. And although they give precedence for CABG over PCI in patients with 3 vessel disease and left main disease, the actual practice is that most of the centers, they use PCI. This is the last slide, and this is the real world experience when you perform PCI in these patients. This is a Korean registry, 12,000 patients. 2/3 of these patients had normal preserved renal function, and 1/3 had chronic kidney disease. And what you see here is they had, of course, stenting, drug-eluting stents, newer generation drug-eluting stents. And what we see here is the target lesion failure. And target lesion failure was defined as cardiac mortality, myocardial infarction, or target lesion revascularization. And as you can see, in patients with earlier stages of chronic kidney disease, they do not have a significant difference from patients with preserved renal function. But in patients with at stage 4 and 5, there is an increase in target lesion failure. But this increase is due to increased death rates, not due to target lesion revascularization. So the same theme again, these patients die not because of coronary artery disease, not because you have stented the coronary artery lesion. They die because of non-atherosclerotic risk factors. The other point, if you wish, and you can look at the article, is that in fact non-target vessel events were more than target lesion events. So again, these patients have active coronary artery disease, and they have new events after you stent them, not because of the stented segment problem, but because of other segments in the coronary arteries or in other coronary vessels. And again, in the study of ischemia, chronic kidney disease, the rate of stent thrombosis at 3 years with the new drug-eluting stents, with the new generation drug-eluting stents, was 0.9%, quite within the range of patients without kidney disease. I think this is the last study, and I would like to thank Dr. Omar very much for joining us. We enjoyed his presence. We learned from his experience.
Thank you very much, Sherif.
I would like to thank Sahir.
Thank you very much. Thank you very much.
And the last
شريف ممكن اقول حاجه بس؟
ثانية واحدة بس، ما اعرفش ياسر حط اللاست سلايد ولا لا، انما انا بعت لك يا ياسر الريفرنسز، انا كاتبهم كده في one last slide. اتفضل يا عمر.
هو بس حد كان بيسأل على اللونج تيرم kidney donation on the donors. هي الحقيقه انه في نسبه بيجي لها رينال فيلير، والنسبه دي حوالي 4 كل 10,000 واحد، ودي نسبه ضئيله، يعني نسبه تقريبا مساويه للجنرال population. وفي 20% of them they get mild hypertension and maybe mild proteinuria after 25 years of donation. The long-term effect of this is not really known, but unfortunately in Egypt you don't have proper recording of this. But in the Western countries they have a proper recording of the donors, and they up till now allow the kidney donation from living donors. I personally have encountered 2 cases of renal failure that occurred in patients who donated their kidney. And these patients were mothers who donated their kidneys to their sibling, to related donors. After 22 years, 23 years, they developed hypertension, and 7 to 8 years later, they developed renal failure. Probably they were not well managed. And this is very important. If a person donate a kidney, he should be assessed, say, yearly at least, for his blood pressure, his proteinuria, his kidney function. And this is not easy in Egypt. Thank you.
Thank you, Omar. I would like also to thank Dr. Ahmed Kamal because he prepared the presentation for me. Thank you, Ahmed. Dr. Mohammed Abdel Ghani, please take over.
شكرا دكتور شريف، شكرا دكتور عمر. احنا كلنا الحقيقه استمتعنا بالمحاضره الجميله وبالمناقشه الاجمل. احنا هنفتح باب الدسكشن لمده 10 دقائق. اسمحوا لي بس اتكلم على نقط اساسيه ممكن نتفق عليها. النقطه الاولى، احنا بنتكلم على رينال ترانسبلانتيشن ريسيبيانتس. العيانين دول definitely عندهم more risk factors than general population، وبالتالي هم at high cardiovascular risk. الأخبار الحلوة إن الرينال ترانسبلانتيشن كان reduce الريسك ده، بتقلل الموربيديتي and mortality. مهم جدا في العيانين دول إن إحنا نعمل بروبر سكريننج. ليه؟ عشان احنا قلنا ان هم عندهم هاي كارديوفاسكولار ريسك. مفيش اجريمنت واضح على بروتوكول فور سكريننج اوف كارديوفاسكولار ديزيز للناس دول، لكن في ديفرنت جايد لاينز. الناس دول الشيست بين ما هواش دلاله على الاسكيميك هارت ديزيز، بمعنى ممكن يكون عندهم سايلنت اسكيميا. النون انفيزيف تيستنج ده كورنر ستون في السكريننج، لان احنا ما نقدرش ناخد كل عيان نعمل له كورونري انجيو. السؤال المهم، مين اللي هنعمل له كورونري انجيو؟ هو العيان اللي هيطلع هايلي بوزيتيف نون انفيزيف تيست. طيب مين العيان اللي بعد كده ابعته يعمل ريفاسكولارايزيشن؟ اكيد هو العيان اللي عنده كريتيكال كورونري ارتري ديزيز او اللي عنده ليفت مين ديزيز. ولما احط ستنت احط السبيشال ستنتس اللي انا ممكن اوقف بيها الديوال انتي بليتلت افتر شورت بيريود. العيانين دول بعد رينال ترانسبلانتيشن ستيل ات هاي كارديوفاسكولار ريسك عشان الاكتيف ديزيز. فمهم جدا ان انا اكمل اجريسيف ريسك كنترول عشان العيانين دول يفضلوا سيف. ايه العيان اللي انا ما اقدرش ارجعه للدكتور عمر الخشاب اقول له حضرتك تعمل ترانسبلانتيشن؟ يعني ايه هي الكونترا انديكيشن فور رينال ترانسبلانتيشن؟ اظن ان احنا متفقين العيانين اللي عندهم سيفير ليفت فنتريكولار ديسفانكشن مع كورونري ارتري ديزيز، العيانين اللي عندهم كريتيكال كورونري ارتري ديزيز، العيانين اللي عندهم ادفانسد سيفير فالفولار ليجنز لازم نصلح الليجنز دي قبل ما نبعتهم يعملوا ترانسبلانتيشن، العيانين اللي عندهم برضه هاي بالمونري ارتري بريشر. العيانين دول مش بس هاي اوبريتيف ريسك، ده هاي ريسك اللي بعد كده. في نقطه كان اثرها اظن الدكتور هشام يحيى كان بعت سؤال، يا ترى العيان اللي عنده سيفير ليفت فنتريكولار ديسفانكشن العيان ده هقدر ابعته يعمل رينال ترانسبلانتيشن؟ في ناس كتير بتقول ان اليوريميك كارديوميوباثي دي ريفرسبل، وبالتالي لو العيان عنده نورمال كورونري انجيوجرافي وعنده ال في ديسفانكشن ممكن ابعته يعمل رينال ترانسبلانتيشن وان ذا فيوتشر هيحصل امبروفمنت اوف كاردياك فانكشن. ما اعرفش دكتور عمر رايك حضرتك ايه، والدكتور شريف راي حضرتك ايه في النقطه دي؟
اتفضل يا عمر.
حضرتك الريفرسال اوف ذا myocardial problem can occur particularly in children. يعني الاطفال الصغيرين مش صغيرين قوي، يعني ال 15 و 16 و 14 سنه they can revert their myocardial toxemia or myocardial cardiomyopathy by doing transplantation, and a lot of these patients do transplant and after less than 6 months, they become completely normal. But in older patients, which is the majority of the patients, I don't know if this is going to be right or wrong, because we already avoid transplanted patient with a ejection fraction below 35. You cannot transplant a patient with an ejection fraction of 20 who is 40 years old. This is a very, very, very high risk per person. But in children, we did it, and I have a special case whom I referred to Professor Sherif, and he advised to do the transplant, and I did it. And this patient improved very well, but he was a 13-year-old child.
دكتور شريف في الطب رأي حضرتك ايه في الحكايه دي؟
انا موافق على الريزيومي اللي انت قلته ده برضه، انا موافق.
تمام. دكتور ياسر ممكن نفتح باب الدسكشن. انا شايف هي دكتوره وفاء عندها سؤال. نعمل انميوت للدكتوره وفاء. دكتوره وفاء العروسي.
مساء الخير دكتور شريف، مساء الخير دكتور عمر. Thank you very much for the illustrative. أنا كنت مستنية المحاضرة دي من أول ما تم الإعلان عليها، لأنها بتشكل very big question in the clinical scenario of such patients. والاستفسار بتاعي كان زي الاستفسار بتاع هشام يحيى. Patients with poor LV function ranging ما بين 30 and 35 ejection fraction, whether it's estimated by 2D echo or 3D echo زي ما هشام كان بيثير النقطة دي. أنا ببقى هنا محتارة فعلا، هل ده myocardial reserve poor will not benefit of the transplant? Denying patient of such a beneficial procedure might be a very difficult decision to take. Is stress echo or dobutamine stress echo can help زي ما بنعمل في valvular lesions with poor LV function to predict the reserve of the myocardium, or shall we give it the final decision زي ما دكتور شريف عمل في عيانه, let's give the poor patients a chance?
هو ده طبعا وفاء بعد الاوبتمايزيشن، بعد الاوبتمايزيشن
the medical treatment طبعا.
Many patients they improve when you follow them up on beta blockers, mineralocorticoid antagonists, and ACE inhibitors. They improve, and they improve remarkably. وبعدين عندي كمان الريسنكرونيزيشن cardiac therapy. فبعد كل الحاجات دي ejection fraction فضل low زي عمر ما بيقول. patients at high risk during surgery because of the volume load and the volume shifts, and at high risk after surgery because of the continuous cardiovascular disease burden.
دكتوره وفاء يمكن كمان لما تلاقي العيان ده هو اطلبي من الريفيرنج نفرولوجيست ان هو يعمل اجريسيف داياليسيس ساعات مع المور فريكوينت سيشنز او الاجريسيف سيشنز.
هتقدر تغسل يا محمد اكتر من 3 مرات في الاسبوع؟
لا طبعا تقدري. انا عندي عيانين لما طلبت ان السيشنز تبقى اكتر وتبقى مور اجريسيف اتحسنت اليوريميا، لان احنا بنتكلم على يوريميك ميتابوليك كارديوميوباثي. العيان ايجكشن فراكشن اتحسن وديفينتلي قدر يعمل ترانسبلانتيشن، وبعد الترانسبلانتيشن اتحسن اكتر واكتر. العيانين دول should not be doomed as
This is what I was asking about.
دي مهمه جدا. بالظبط.
I might be looking for the estimation of ventricular function with the regional or global by tissue Doppler global strain. Would it differ on than the ejection fraction in the prediction of myocardial reserve? I will go and look for it في literature. أنا ما عنديش المعلومة دي. إذا كان حد من الزملاء المطلعين أكتر مننا يقدر يجاوب عليها. Can we use the global strain as a better predictor of myocardial reserve than the ejection fraction in such patients?
انا اظن ده كان حاجه من الانترست بتاعت الدكتور عزه فراج، هي كانت اشتغلت على عيانين رينال ترانسبلانتيشن بيشنتس بيفور اند افتر. انا اتمنى اللي هي لو كانت معانا كانت ممكن تجاوب على السؤال ده، لكن ممكن نرجع لها.
اوكي.
على فكره and I would like برضو to draw the attention of everybody انه there are large opportunities for research in this subject. احنا اتكلمنا على research in early stage kidney disease, research in the what renal transplantation can have as reversible effects على ال vascular system وعلى الميوكارديوم. there is a large opportunity for research in these fields.
دكتور ياسر شرف.
مساء الخير يا محمد. خير، في حاجة؟
حضرتك عايز تعمل كومنت يا دكتور ياسر على المحاضرة؟
هو بس الفكرة بالنسبة للكانديديتس اللي هو الeligible candidates for renal transplantation، كل سنتر بيبقى له eligibility criteria. في absolute contraindications و relative contraindications. من ضمن الابسولوت contraindications السيفير pulmonary hypertension زي ما الدكتور شريف قال فوق 60، والسيفير left ventricular dysfunction يعني ejection fraction تحت 35%. في relative contraindications لو كان العيان في heart failure والايجكشن fraction اكتر من 35، this is a relative contraindication. بس زي ما الدكتور عمر الخشاب اللي قال، الكارديولوجيست لازم هو بيبقى عنده ريسك اسسمنت. لو كان السرفايفل بتاع العيان ده curtailed وشورتند مش هيستفيد حاجه من الرينال ترانسبلانتيشن، وممكن قوي يكون هيموداياليسيس سيمبل وسيف ويبقى وايزر ديسيجن. فده وجهه نظري. لكن الجايد لاين سوري الريلاتيف والابسولوت كونترا انديكيشنز دي موجوده في الميجور سنترز، موجوده في حاجه جايد لاينز اسمها كيديجو 2018، ممكن الناس ترجع لها. لكن اختلاف نقيس الايجكشن فراكشن ازاي this is not the point. هم من الخبرات بتاعتهم لما تبقى الايجكشن فراكشن از لو، في نوع بيبقى ريلاتيف كونترا انديكيشن ونوع بيبقى ابسولوت كونترا انديكيشن.
تمام. دكتور هشام يحيى كان عنده سؤال. دكتور هشام. اوكي. دكتور وليد عمار ليه كومنت؟
اي دكتور محمد، مساء الخير.
اتفضل يا دكتور هشام، اتفضل.
هو طبعا كان السؤال الاولاني بتاعي عن الاستيميشن بتاع الايجكشن فراكشن في العيانين دول. يعني دكتور عمر قال كات اوف بوينت اللي هو 35. طيب احنا بنشوف حالات كتيره طبعا عامله ايكو، الاسسمنت بتاع الايجكشن فراكشن ده ما بيبقاش اكيوريت قوي فيهم، سواء نتيجه الديفرنت لودنج كونديشنز او ان هو اعتمد على قرايات ثانيه او ان الايكو ويندو بتاعه مش واضح قوي. فهل كنت بسأل هل في اي اوبشن لموداليتي ثانيه ان احنا اكيوريتلي استيميت الايجكشن فراكشن ده علشان نقول هل ده 35 او اكتر من 35؟ الام ار اي طبعا از ذا جولد ستاندرد بس في العيانين اللي عندهم رينال فيلير مش هيبقى. فده اول سؤال. السؤال الثاني كان بالنسبه للعيانين اللي هم عندهم هارت فيلير with preserved ejection fraction، الريسك اسسمنت بتاعهم هيبقى ازاي؟ لانه طبعا ممكن ما يبقاش مستحملين الفلويد اوفرلود اللي ممكن بيحصل اثناء الترانسبلانتيشن.
واكشولي معظم العيانين دول اللي عندهم هارت فيلير وبريزرفد ايجكشن فراكشن، انت بتتكلم على عيان فيري سنسيتيف للفوليوم اوفرلود وعيان عنده ليفت فنتريكولار هايبرتروفي. لكن هل ده محطوط من ضمن الاكسكلوجن كرايتيريا اللي يعمل رينال ترانسبلانتيشن؟ ممكن يحطه على هاي ريسك لكن مش هيحطه على الاكسكلوجن. دكتور شريف براي حضرتك ايه في الحكايه دي؟
هو الهارت failure with the preserved ejection fraction is not well studied in these patients. وبرضه this is another opportunity for research. دي حاجة برضه ممكن حد يبص عليها ومش هيلاقي في الليتريتشر enough data، ودي تبقى good opportunity for research. Definitely these patients should be well controlled in terms of atrial fibrillation, hypertension, pulmonary congestion. they should be well controlled before surgery. وهو لازم يتعامل معاملة decompensated heart failure with preserved ejection fraction. لازم يتعامل معاملة decompensated heart failure with reduced ejection fraction.
سؤالك الاولاني دكتور هشام، ممكن طبعا البلاد جيتد نيوكليير ستاديز تقيس برضو الميوكارديال فانكشن بطريقه مور اكيوت. دكتور وليد اتفضل.
شكرا دكتور محمد. شكرا دكتور شريف، دكتور عمر على المحاضره القيمه جدا. اول سؤال، patient still in chronic kidney disease phase before end stage renal disease, how can we slow down vascular calcification at this stage? السؤال الثاني، هل do we have data in kidney transplantation may reverse vascular calcification and vascular function in such patients? شكرا.
دكتور عمر.
ايوه، هو طبعا المين كوز اوف فاسكولار كالسيفيكيشن بيبقى disturbance in the calcium, phosphorus and parathyroid hormone levels, and both three are important. After renal transplantation, both three, if of successful transplantation, both three revert to near normal or normal, but this can take up to 6 months. I mean, it's not on the second day of transplantation. You need to wait for 6 months to judge about the calcium, phosphorus, and hyperparathyroid benefit of transplantation. If this occurs and the transplant is successful, the calcium, phosphorus, and PTH return to normal, which is a common finding, these patients definitely on the long term, they will get some reduction in their coronary calcification.
انت عارف يا وليد،
ايوه دكتور شريف،
انت عارف you can do a study. بص في literature and then you can do a study. هو الكورونري كالسيوم سكور serial studies بتوري ان هو مش بس بيزيد as the GFR is reduced، لكن كمان in a certain patient هو بيزيد with time. يعني serial studies coronary artery calcium score تلاقي ان هو بيزيد with time. انا ما اعرفش بقى الستاديز اللي بصت على reversal of this process، على انه الكورونري artery calcium score يبتدي يقل with time after renal transplantation. ممكن تبص في الليترشر وممكن تعمل انت الستادي دي. اظن يا دكتور عمر كمان انه في ستادي استعملوا الفوسفات بايندر in patients on dialysis.
Yes.
But it was a negative study. It did not result in reduction of mortality in these patients.
Yes, because most of the phosphate binders used in the past were, and up till now, they are calcium phosphate, calcium acetate or calcium carbonate. These are contain calcium in them, and this is one of their disadvantages. They might increase the coronary calcification, and so they invented the new category of phosphate binders that bind the phosphate and do not contain calcium. And they claim that this is a much better treatment, but most of the studies really, as you said, did not show a real advantage of these over the traditional calcium acetate. And I'm particularly saying calcium acetate because calcium carbonate contain more calcium than calcium acetate. So in these patients who have massive coronary calcification, and particularly in old dialysis patients, it's much better to use calcium acetate, not the calcium phosphate, the calcium carbonate. So calcium acetate, if you compare it with the new phosphate binders, they did not show a real advantage over calcium phosphate, but they are very expensive. And the problem with these phosphate binders, which are non-calcium containing, is that in the early phase of their production, which is the one present in Egypt now, they contain hydrochloric acid, and this can cause some acidosis in some patients. So it's very expensive, it can cause acidosis, and there is no real evidence that it is beneficial. And that's why abroad, say 5 years ago now, they replaced this, it's called the, I don't want to mention the names, but they replaced this non-calcium phosphate binder with new one containing bicarbonate. And this is the one that is used in Europe and United States now, but it's a very expensive drug. So unless it shows a very clear advantage, it's not going to work in Egypt to use a very expensive drug to get a very small benefit after 5 years. I don't think this is commercially right.
نسمع كومنت من الدكتور عصام بلير.
دكتور محمد.
دكتور عصام اهلا بيك.
محاضرة عظيمة جدا بتاع الدكتور شريف والدكتور عمر يعني، وكان هو السؤال اللي انا كنت اساله هو كان نفس السؤال بتاع الدكتور وليد، هل الاثيروسكلروزز اللي بيظهر في العيانين دول حاجة ريفرسبل ولا لا؟ يعني العيانين دول بعد الترانسبلانتيشن هل في رول الترانسبلانتيشن انه بيقلل الاثيروسكلروزز عندنا ولا لا؟ يعني احنا مثلا لما كنت بنشوف العيانين دول واحنا بنعمل لهم الدوبلكس بنلاقي الانفرابوبليتيال ديسيس عندهم بيبقى سيفير واجريسيف، وفي الاثيروسكلروز كالسيفيكيشن بيبقى فيري ادفانسد في البريفرال فيسلز. هل ده بيتحسن بعد الترانسبلانتيشن ولا لا؟ واي ثينك انه زي الدكتور شريف ما بيقول ان احنا نقدر نعمل ستادي. طبعا لو قدرنا نعمل فولو اب للعيانين دول بالدوبلكس احنا ممكن ناسس الكالسيفيكيشن دي اسهل من كوروناري كالسيوم سكور، وهتبقى مور تشيبر عن واحنا عاملين ستادي دلوقتي على الكالسيفيكيشن في الكوروناري وفي الفالفولر عموما في الاثيروسكلروز والكورليشن بتاعتها مع الريسك فاكتورز، على اساس ان احنا نقدر ناسس الكالسيفيكيشن هل كاردياك او اكسترا كاردياك بالدوبلكس وبالايكو. فدول ممكن يبقى سهل ان احنا نقدر نعمل لهم فولو اب بعد الترانسبلانتيشن لو كان عندنا ستادي قبل الترانسبلانتيشن، بس عيبها انها لازم تعمل لونج تيرم فولو اب، يعني لازم اتليست سنتين على حاجه عشان نقدر نقول انه بيحصل ريجريشن للاثيروسكلروز او للكالسيفيكيشن دي.
عصام طبعا هو السؤال مهم، بس انا عايز اقول ان انا الاثيروسكلروزس انا بخاف منه من ايه؟ انا بخاف منه من الكارديوفاسكولار موربيديتي اند مورتاليتي. احنا عندنا definite statement ان الرينال ترانسبلانتيشن كان improve الكارديوفاسكولار موربيديتي اند مورتاليتي. فاحنا متفائلين ان ده بيحصل عن طريق reversible of atherosclerosis، لكن ده عايز استادي زي ما الدكتور شريف باشار. عايزين نسمع final comment from our host بروفيسور دكتور ياسر بغدادي.
شكرا يا دكتور شريف، شكرا يا دكتور عمر.
احنا اللي بنشكرك يا ياسر.
شكرا يا ياسر.
لا يا فندم، محاضرة رائعة بصراحة. ربنا يكرمك. أنا بس يا دكتور عمر كنت عايز أسأل حضرتك دلوقتي، إحنا بالنسبة لنا إزاي نخلي في دراي ويت عند البيشنتس اللي موجودين دول اللي هم على الرينال داياليسيس، بالذات في الأوقات اللي ما بين الداياليسيس ساعات بيبقى بيسويل أب وذ ووتر وأنا مش عارف إيه حلها حقيقي. وهم
This is true. بص حضرتك، هو زي ما قال دكتور محمد ان في patients you have to increase the frequency of dialysis, but some patients are totally non-obedient. They drink a lot of water amounts that can be يعني very astonishing. يعني عيان مثلا ما بيجيبش بول وبيغسل بقاله 5 سنين ويشرب 4 لتر ميه. طب اذا كنت انا ما بشربش 4 لتر ميه، يعني حاجات غريبه قوي. بيحطوا ملح كتير قوي في الاكل، فهو العيان ساعات يبقى non compliant بطريقه وحشه قوي. The only way to do this is to try to instruct him and maybe to increase the frequency of dialysis a little bit. ولو ان هو لو زودت الفريكونسي اوف dialysis هتقلل صحيح البردن of fluid overload and fluid removal from the body, which is also, by the way, very injurious and is a major factor in the cardiomyopathy for these patients. The fluid shifts across the cells is injurious to the myocardial cells, to the muscle cells, to the brain cells. You try to explain to him this so as he can reduce his water intake and of course reduce his salt intake. But there are patients who do not respond to this, psychologically disturbed perhaps. There is no other way except to increase the frequency of dialysis.
شكرا يا دكتور عمر. اتفضل يا دكتور محمد.
في ختام الأمسية الجميلة دي هي لا يسعني إلا أن أشكر صاحب الأمسية أو صاحبي الأمسية، الأستاذ الدكتور عمر الخشاب والأستاذ الدكتور شريف التوبجي. احنا خدنا وعد من الدكتور عمر ان احنا هنعمل فيوتشر جوينت ايفنتس، هنعمل هارت كيدني كروس توك ان شاء الله هنوضب لها وهنعلن عنها، وتبقى محاضرة النهارده بداية لسلسلة من الجوينت سيمينارز between cardiology and nephrology department. اشكر كل زملائي اللي كانوا موجودين النهارده ونشوفكم على خير. شكرا جزيلا.
شكرا دكتور ياسر. شكرا شريف.
شكرا. تصبحوا على خير.